Can you hear me?
Yeah.
Yeah. Good morning, everybody. And thank you very much for your kind words, Nivi. So without further ado, let me just start sharing my screen.
Yeah. Videos, audio is available. Yeah. Good.
Yes. Yeah. So good morning, everybody. And let me first thank Dr. Nivi for this fantastic platform and her thoughts and her approach towards managing patients is phenomenal, sort of echo her sentiments quite a bit in whatever we do. And so in the same ethos, we sort of practice, and this talk is also sort of channeled towards the same thought process in terms of collaboration. And we are all together in the care of patients, and we shouldn't be like the set of blind men who are describing an elephant. Instead, we should open our eyes to see the elephant as a whole and let each of us who are masters of our own speciality describe and treat the elephant as it is so that the patients benefit. So the last 10 years has been a sort of renaissance in the management of obstructive sleep apnea. Let it be dentists, let it be surgeons, let it be physicians who are in the care of these patients. We have become more and more anatomically targeted, pathophysiologically targeted towards the management of these patients. We are also in a stage where we started to question the authority of CPAP as a standalone gold standard, no other option therapy, to where we are able to offer non-PAP sort of therapies to patients. Let it be appliances, let it be positional therapy, let it be surgery, whatever it is, because the concept and the dogma was sleep apnea starts with CPAP and ends with CPAP. And if you don't use CPAP, that's the end all kind of a scenario, which is not the case today. However, the concept of success of treatment of sleep apnea, whether you use surgical methods or non-surgical methods, the concept of success has unfortunately still remained the same. That means you need to not only reduce the AHI by 50%, but you need to reduce it also below 20. So it is 50% and below 20. So the concepts of how we achieve success have changed, but the end result, sort of the goalpost, somehow we're still not able to change. But there's a lot of work going on in that direction, and probably in the near future, that's going to change as well. What has also changed is how we look at patients with sleep apnea. When you close your eyes, the first thing that anybody would think of is a silhouette of this male patient who's obese, with a short neck, with a big belly, with complaints of snoring and excessive daytime sleepiness. But that concept has also completely changed over the last 10 years. People started realizing that sleep apnea is not a condition that only favors the male gender, or only the older males, or people who have a particular kind of a body silhouette. It can affect women, it can affect children, it can affect males with all kinds of sizes and shapes. So that stereotypical description of a sleep apneic patient being of the male gender, being with a short neck, having central obesity has also changed. We now know that sleep apnea can affect many people and it manifests differently. So if we are not picking these patients up, That is because we are not asking the right questions. Because sleep apnea presents differently with two different people. For example, how can you ask a child symptoms of having excessive daytime sleepiness, or he will not say that. So every kind of patient need to be sort of evaluated very differently. Of course, that's a different discussion for a different time. The take-home message that I would like to give at the end of this slide is that sleep apnea is not a gender-friendly kind of a disease. It's not a shape-specific. It affects all shapes, all sizes, all ages, all genders. But it does not manifest itself the same way. That is very, very important, especially when we talk about questionnaires that we use to pick up patients with sleep apnea. This is a questionnaire that all of us use across specialties, dental sleep, ENT sleep, anesthetists, to sort of look for patients who have sleep apnea because they come with their own complications and their own presentations. Stop Bang is a validated questionnaire, but a validated questionnaire for whom? It is not for us as South Asians, because most of these questions in the Stop Bank questionnaire, for example, the BMI. If you take Indians for that matter, our BMIs will be low, but we are very heavy at the center. We have central obesity that makes us more vulnerable to a lot of other diseases like metabolic conditions and all that. So even with a lower BMI, we get a lot of metabolic conditions like diabetes, so on and so forth. And that's a question that we sort of answered, or we sort of put in as a communication, which we published in the Indian Journal of Otolaryngology, wherein we spoke about how Stop Bank questionnaire is inadequate for the Indian and South Asian context. And this is a recently published data. This is from July. That is published in the ERS journal, a very, very reputed journal. This is the European Respiratory Journal. And this is one of the studies. This is a study that's been done in AIMS Bhopal by Abhishek Goel. We had the fortunate experience of having him at the IASSA Con, wherein he actually spoke about this paper. This is one of the largest studies ever done with a level 1 PhD. And this is done in India. And it was found that in India, the prevalence is 32.5%, not the 7% that got published in 2007. In 2023, the prevalence in India is 32.5%. And that is when they used an AHI of 15, not 5. When they used an AHI of 5, the numbers went bizarre. So they decided that we will use an AHI of 15. AHI of 15 is where AISM sort of tells us to use CPAP. So that is the cutoff that they have used. And they found out that the prevalence in India is 32.5%. That is extremely high. That brings us to the point where there is scope for everybody, and a lot of us who are even inclined to the management of patients with airway-oriented dentists, airway-oriented ENT surgeons should be looking at and managing these patients. So we have clearly moved on from PAP for everybody, from surgery for everybody, to our device to everybody. We have completely moved to what the patient needs. And also, I would like to put up my point here that, every patient is different. We are actually sort of labeled as Western medicine. We are supposed to be the torchbearers of Western medicine. Is all about stratifying patients, putting them into pools and giving them, okay, this patient has this. They all need one kind of therapy. I think COVID was a rude wake-up call for that kind of an approach. We saw a lot of our patients having COVID but each of them manifesting differently, responding differently, and having outcomes very differently. The same kind of principle applies for a lot of these conditions, and sleep apnea is one such condition. So every patient that walks into your chamber, walks into your clinic, needs to be evaluated specific to their clinical domains and should be customized based on what is the underlying mechanism that is driving that particular disease for that particular patient. That is primarily true because OSA is a condition which is multifaceted, which is very clearly seen in this particular picture, wherein you know that the narrow, crowded airway is a common denominator for all patients with OSA. But what is not common is how they respond to airway collapse, how they respond to carbon dioxide getting retained in the body, and how they respond to increased work of breathing. All of these are basically other parameters that define how the patient manifests to you and how they respond to a particular treatment modality. This is something that we sort of tried to explain in a chapter that we've written in the sleep medical clinics, wherein if I have to put it in a diagrammatic format, airway collapsibility is common for all patients with obstructive sleep apnea. They may have mild airway collapsibility, they may have severe airway collapsibility. So I would like to break it down into very simple terms. What is airway collapsibility? It basically means how the upper airway is basically responding to the negative pressure that is being generated, partially caused by the obstruction proximal to the airway. When I talk about airway, I'm talking about pharynx. And the determinants which are higher up above the pharynx that are resulting in that negative pressure in the upper airway. Now that can be from -2 to +2. For patients with severe sleep apnea, it can be even to the measure of +2. That means even a pressure of +2 in the pharynx can collapse their upper airway. So we are looking at patients who are very, very vulnerable to collapsibility. Now, this determinant, which is the basic denominator for all our patients with obstructive sleep apnea, is influenced by these particular three parameters. Now, what are these? These are how a patient responds to increased work of breathing. That means if a person is working hard to breathe because of obstruction happening either at the level of the nose, either at the level of their jaw, or either because the tongue is falling backwards, and that person is requiring to breathe harder, and if the person's brain is waking up just by that increased work of breathing, that is arousal threshold. If a person is having ventilatory instability because of the disproportionate increase in carbon dioxide, that is loop gain. And once the airway is collapsing, the dilator muscles, how they are responding to that particular negative pressure in the upper airway, that is muscle responsiveness. Now, once you have this complex phenomena together, and any of these things working slightly away from the way they should, results in sleep apnea. So, how do you know which of these are working properly? That you will know on understanding your sleep study very well. Now, even if you take the upper airway for that matter, now I'm talking about the denominator, which is the peak rate, which I talked about as airway collapsibility or the vulnerability of the upper airway to collapse. Even that is different at different levels. This is all airway. Nose is airway, mouth is airway, pharynx is airway, larynx is airway. But look at how each one of them respond to. So if you look at the nose, it has a very high and fixed resistance, but very less compliance. That means collapsibility. The mouth has a very high resistance and low collapsibility. The pharynx, on the other hand, has low resistance but greater compliance. So even the peak rate for that particular individual, based on what subset or the level of obstruction you're talking about, matters. Hence, dear colleagues, I would like you to bring your attention
ऋषभ देखना क्या हुआ है
I would bring your attention to the left side of the screen, wherein do not look for obstruction removal. Do not look for removal of obstruction. Look for reduction of resistance. Okay? Try to improve airflow. So if you are looking at trying to remove obstruction in the upper airway, we are going to fail. Try to improve.
ऋषभ
Excuse me?
इसमें देखना क्या प्रॉब्लम है पॉज हो गया
Vibhuti, could you mute yourself? Yeah, thank you. Sorry about that, Srinivas.
No problem. So what I was trying to say is, because the upper airway has so look at the upper airway as a combination of resistance and compliance. Do not look at improving or removing obstructions. Don't look at removing a particular structure in the upper airway. See, if I clear this, can I improve resistance? That is something that we need to really look at. This is something that you can really beautifully understand if you use a positive airway pressure, a tool that is basically designed to remove or to improve airway. So if you look at this video, basically, what we're doing here is we're doing a drug-induced sleep endoscopy in this patient. We're putting a PAP device and we are looking at the behavior of the upper airway at different pressures.
Okay, make it 9 or 10.
So now I'm giving a positive airway pressure at 10. We're putting the mask there. We're looking at the respiratory rate. This is a PAP device. And now we've increased the pressure to 10. And then you can see a collapse has completely become only a partial obstruction. Now you can see how the palate is opening at that particular pressure. Now we've increased it to 12.5.
Now, obstruction is clear. Make it 16. That's because we put the...
Now at 16 pressure, see what is happening to the airway. Now you can see two ports of entry that are opening up slightly. This sort of gives you an idea as to how the CPAP is behaving in this particular individual. So now we have increased the pressure further.
Wow. Now you can see it.
Now you see how the airway is
20.
So at 20, you can see the airway is completely open. This is how now we know that at 20 pressure, how the airway is opening up for this particular individual, and how we know how to improve the airway and what are all the structures that are contributing there and allowing us to improve the upper
Can you
airway.
make it 25?
So this is a very, very high pressure. 24 pressure is something that is very huge for any patient. They cannot tolerate. So if you give a PAP for this particular patient, see the airway is completely open at 25. Yes, but the patient should be able to tolerate that particular pressure. So when you give CPAP for this particular patient,
Highest
that is
pressure
going to
here.
become very difficult for the patient to accept that pressure.
Okay.
So primarily, now we know that how the
Okay, sir.
airway is behaving
Reduce it
at
to
these particular pressures so
6.
that we can customize the treatment plan for this particular patient.
Sir.
Now, why is all that important? Way back in the beginning of the last decade, we used to do surgical interventions called UPPP, and I'm sure all of you know about these procedures. So when you look at the airway, right, when you look at this palette, to me or to any average ENT surgeon or to any person who is airway inclined, so this airway looks great, right? What's wrong with this? Just look at what happens the moment we put the scope behind that palette. Airway completely sort of is obstructed. This is the only space that is available for the patient to breathe. Hence, what happens is that this patient becomes incredibly symptomatic. So if you have a patient, if you do one kind of a procedure for every patient that crosses your door and enters into your clinic, you will end up giving bad results. So, non-selective surgeries, non-selective treatments to eliminate obstructions can give you success rates anywhere between 80% to 20%, which is just bad.
Srinivas,
No, whether
Srinivas,
yeah.
excuse me, could you mute everybody? You are the host, so you'll be able to do it.
Okay.
Or everybody, all docs, can you mute yourself, please?
Is that all right? Should I continue?
Yes, please, go ahead. Thank you.
Thanks. So these are lessons we have learned from what we have done in the past. And the reason why I brought this slide up is if you bang every patient with a surgery, or if you bang every patient with an MMA, or if you bang every patient with an expansion, your results won't be good. So customization and evaluation is very important. So if you were to look at how we have evolved from the 1960s to today, the newer principles of treatment have completely become very, very sort of conservative. We are addressing the airway as it is a tube, not as something which has got obstructions in it. Try to understand that this is a active breathing, swallowing tube that we should be looking at. So we should respect tissue and look at the behavior of the airway as the air is going through it. What can we do to improve the airway? That should be our primary goal. So when you look at the airway, you should be looking at how conservative should I be? It shouldn't be like, okay, I looked at this. How am I going to clear that out? No. What has caused that situation there? What is the obstruction at the level of the jaws? What is the obstruction at the level of the nose? A lot of times, just improving nasal breathing improves airway. It improves the way that your air. This is something that I will show you in the subsequent slides. Just closing the airway improves the upper airway collapsibility. Our understanding of this has completely changed once DICE has come our way. So if you look at this particular video, this beautiful evaluation of the upper airway has completely changed the treatment plan in about 60 to 70%. And I can tell you just yesterday, there was a patient with severe class 2 skeletal kind of a patient who we actually thought that we would either give him a, after doing the nose and palate, give him a mandibular advancing device or at least do a mortised genioplasty. But to our surprise, the moment we did DICE on that particular patient, he actually didn't show any kind of tongue-based obstruction. What is that telling us? That is telling us that the underlying endotype or the mechanism, which is muscle responsiveness to the negative pressure, is very good. This patient's genioglossus muscle tone is fabulous. And in such patients, we may not need to do any kind of a surgery other than opening up the nose and clearing the palate. And that is how DICE has completely changed the way we look at things. This is another video which I'd like to bring to your notice is if you are looking at this particular video and we are going down the upper airway and we are looking at the level of what we call as the velum. What is velum? Velum is the part of the soft palate that is touching the posterior pharyngeal wall. You can see this is the palatopharyngeus muscle. This is the levator muscle. This is the musculus uvulae. And each of these muscles are very clearly seen how they are coming and causing this complex obstruction. Why is this very important for us? Because if you look at the oropharynx, now if I can see here, you can see this lateral wall collapse and you can see the epiglottic collapse happening. In fact, lateral wall collapse is a fantastic DICE parameter that tells us for sure that a mandibular advancing device works in these patients. You don't have to look any further. The moment you see a lateral wall collapse in these patients and you don't see a complete circumferential collapse at the level of the soft palate, you can actually know for sure that a mandibular advancing device would work. But if you have this kind of an epiglottic collapse happening, would a mandibular advancing device work? No, it won't work. Hence, even before you give a particular treatment modality to your patient, if we are able to look at these kind of images, we can actually understand and improve our strike rate in terms of managing our patients with a particular modality of treatment. So DICE helps us not only to sort of know and understand at what pressure the PAP therapy works, we will also know what kind of a surgical intervention might require, how the appliance or what kind of appliance would help, whether the treatment modality would be a positional therapy thrown into the mix of all these procedures, and we would beautifully know why a particular treatment modality may not work or may work. For example, you have a patient, you've given an appliance, say a beautiful appliance, and you have a treatment failure in this particular patient. A treatment failure may be not only in terms of how the patient might feel, but also objectively, once you've done a sleep study with a device and you found out that the AHI is sort of not reduced that much. Well, there may be many reasons why that may be, because AHI is such a flawed parameter, but that's the best we have today and we have to sort of comply to that kind of a standard. But if you have a patient with treatment failure, either objectively and subjectively, once we do a sleep endoscopy, we may be able to find out why this patient is feeling the way he's feeling. So once you do a sleep endoscopy, we would know based on this kind of a classification, we would know where the obstructions are happening. For example, again, if you have a patient with an anterior-posterior collapse happening at the level of the soft palate, a complete lateral collapse happening at the level of the oropharynx, this is a fantastic case for a mandibular advancing device. look no further. You would succeed. If you also have a complete tongue-based collapse happening at the level of the tongue, is also a very good case for a mandibular advancing device. Why? Because just advancing the tongue forward would bring the palatoglossus forward. Bringing the palatoglossus forward would straighten the lateral pharyngeal wall, and hence your oropharynx is sorted. So these are the kind of parameters that would actually tell you for sure that your strike rate when you are giving a mandibular advancing device would be 100% because you're actually looking at the anatomy and how it is behaving when you give this kind of a or when even before you give the device, you know that the anatomy is favorable. So when you look at this particular patient, and this is you have this particular patient, so I think the video is sort of playing for you. So on this side of the screen, you have the BIS monitoring, which tells you the depth. Here is the endoscopic picture, and here is the dice, us performing the dice. Just wait for the video to kick in. Are you not seeing it, or is the screen frozen?
Yeah, we can hear the audio, but the screen seems to be
Screen
frozen.
seems frozen, right?
But audio is on.
Yeah, audio is on. The video seems to be.
Stop the 55, 56.
Maybe it's on the pause. Check the pause and see if you can hit the play on that.
Paused it and I'm playing it.
So same thing.
Yeah, same thing, right? I can see the taskbar sort of moving. Okay,
Right,
okay.
right.
What I wanted to show you here is that at different sort of head positions, just moving the head here and there can actually change the upper airway anatomy. I wish I could show this. Shall I shift to presenter's view? Maybe that will.
To the right side.
With your permission, shall I just?
Yeah. Please, yeah.
Yeah, sorry. Let me just go into.
22 is a slide here.
Yes, I'll stop sharing and
Okay.
I just go into video settings. Mirror my video, advanced, sending video, video rendering. Okay, everything looks optimized quality of the video.
Shouldn't make a difference. It will probably
Let me
miss the
just,
clarity.
okay, let me just start sharing again. Or move this window away from the shade application. Okay, let me just are you getting the
Right, you have just started. We are still at a blank screen right now.
correct? It's probably my network.
Could be.
Yeah, because sometimes it just gets
In and out, right? Yeah.
yeah.
So maybe stop share and share again.
Again, yes.
We're good on time. Take your time, no issues.
Thank you. Thank you. Nice. Participants can now see your screen. Okay, I think I've changed some of that.
Just run a slide and see if you're able to
Yes, I will.
something.
Yes, I will just let me just stop the PowerPoint once.
Yeah.
It says takes. Yes. So now
Okay.
So meantime, everybody just mute yourself, please.
just think- point is really sorry, guys. Something
No,
is
no problem at all. No problem. So is your PowerPoint open on your screen?
yes, it says I think it's a very video heavy kind of a
Yeah, you probably, because you're playing videos, you probably need a lot
yes.
more.
Or yes. So now okay, let me just take this down. Okay, now let me okay. Did you get it?
Yes, you're on the video screen now.
Okay. And
You
let
can go full screen if you, yeah, perfect, perfect.
yeah, are you getting the screen, the video again? But again, it's the same thing.
Right, right.
I think there has been a question in the chat box.
Yes, we could do the
We'll
questions
take the
later if you
questions
want,
later,
or,
right?
right.
Okay, I'll let it be. I don't think I'll rock this boat. So
Okay.
I just wanted to convey here that the way you can actually look at how position helps. So most of the time you want to give a device or you do a surgery, position sort of changes a lot of our treatment outcomes because OSA is a condition which is caused by obstructions at multiple levels with multiple sort of mechanisms going on in the underlying as an underlying program. So if you do a device or a surgery and just shift the patient to the side, that itself can change the dynamics a lot of
55,
times.
56.
So when you do DICE, we already know how a CPAP sort of behaves. And this is a beautiful paper that's come out of Stanford that basically said at a nasal CPAP pressure at 10, the greatest impact was on the lateral walls. That is exactly what we saw on the video that I showed you earlier. And as the lower airway getting involved in these patients, for example, tongue base or epiglottis, it basically the pressure is increasing to almost 15 centimeters of water pressure. So what is this telling us? That it's telling us that as you go down the upper airway, if there are obstructions in like tongue-based obstruction, for example, you can actually alleviate that or increase the airflow by just giving a mandibular advancing device to these patients, because we know that tongue-based obstructions responds beautifully to mandibular advancing device. So you want, if the patient wants to go with a complete PAP therapy and he's not getting the result that he wants with PAP therapy, or the pressure is too high, you can just customize a nice mandibular advancing device for this patient, and the patient can use a PAP therapy along with the mandibular advancing device, wherein combination therapy can work beautifully for these patients. Because as of even right now, the mandibular advancing device is only for mild to moderate obstructive sleep apnea. It is still not validated for severe sleep apnea. But combination of therapies, that is CPAP with mandibular advancing device, can work beautifully in your patients with obstructive sleep apnea. What can also, where DICE can also make a huge difference for your patients, is where you have a patient with incomplete response. So you have a patient with incomplete response. So what is happening there, right? If you have, this is a beautiful paper that came from Ryan Seuss and David Ken, wherein they actually found out that in a patient cohort of 35 patients who were incompletely responding to oral appliance therapy, they found out that an obstruction at the level of the velum, and I will come to the description of the type of obstruction at the velum, and obstruction at the epiglottis led to less improvement in the outcome for your mandibular advancing device. Imagine if you were to know this beforehand. Imagine you knew this even before you gave the device. You would have actually customized the treatment, because how do we know that? If you that, and I will describe that in the next kind of next slide, that if a patient would have a complete circumferential collapse, that means at the level of the palate, there is a complete collapse happening at the upper airway, a mandibular advancing device will not give you the result. Why? Because the mandibular advancing device brings the palatoglossus forward and straightens the lateral pharyngeal wall, and it can also bring an anterior posterior collapse at the level of the palate forward. But if there is a complete collapse happening at the level of the soft palate, it may not be able to give you 100% result. This is exactly what was published in the paper by Oliver van der Weyken, who basically collected again 72 patients, who were of which 33 patients were good responders to over-appliance therapy, and in 17 patients, they became worse. So it was found that patients with complete retropalatal collapse with a CCC, what we call as complete circumferential collapse at the level of the palate, the odds of having a oral appliance work is pretty bad. So if you were to give this particular patient with an oral appliance without knowing what is the pattern of collapse happening for this patient, there is a chance that you may not succeed very well. Hence, if we collaborate and do a DICE before giving a mandibular advancing device and look at the phenotypes of collapsing in the upper airway, our strike rate of getting good results would be pretty high. So overall, pre-oral appliance therapy, DICE was a very good screening tool in predicting which are the patients who would respond both clinically and subjectively to non-PAP therapies. So is the case with maxillomandibular advancement. It has been found that both mandibular advancing device and soft tissue surgeries that we do very poorly if you were to have a complete circumferential collapse at the level of the soft palate. But this pattern of collapse is not a contraindication to do a maxillomandibular advancement. So, in fact, a beautiful indication to do an MMA would be a complete circumferential collapse wherein you're bringing both the jaws forward. It has also been found, based on DICE findings, that complete oropharyngeal lateral collapse can also respond beautifully to MMA. So DICE also helps us to pick up patients for double jaw surgery. Another problem that we nowadays encounter is just not AP deficiency, it is transverse deficiency as well. If you can see this middle-aged lady here, this teenager here, and this man at 35 years age, very significantly, this is something that us as ENTs and y'all as sleep-aligned dentists see. This is almost like an epidemic in our country, which we failed to see earlier, which was glaringly looking at us, but we just failed to look at this particular entity, which we all know as transverse deficiency of the maxilla. So look at how these patients are. Look at all these patients. What is common with these? And if you see the top video here, they're doing an intraoral. Look where the tongue is. All these patients have significant transverse deficiency of the maxilla. There is no space for the tongue to park itself because of the transverse deficiency that is happening at the level of the maxilla. If you do any kind of a surgical intervention for these particular patients without treating this condition, or even if you offer a hypoglossal nerve implant, which is one of the biggest bazookas that we have to offer for these particular patients, it has been found to be associated with poor outcomes. This is something that we all have to realize in our practice, that not looking at the patients just when they are awake in our clinics. We need to also look at their sleep videos. So asking the patient attendants or the sleeping partners to get the sleep videos and see if they are mouth breathers or no. If you ask the patient, are you a mouth breather? He'll say no. Obviously, he'll say no. But if you ask him, do you get up in the middle of the night to drink water? Or do you, when you wake up in the morning, do you feel like getting up in the morning and drinking a glass of water? They will say yes. These are surrogate sort of history markers for us that these are patients with mouth breathing. So, if you look at these particular patients and if you were to get scans of these particular patients, whether you get a CBCT or a regular CT, this is almost like a given. This is the arch, this is the tongue lower down. And we all know that when we close the mouth, if your tongue is not able to feel their entire soft palate and your hard palate, or your palate is not able to feel your tongue when your mouth is completely closed, you are looking at this kind of a scenario. Now, why is that so important? Why is that we as airway aligned specialists need to understand this concept very much? Because it has been shown again that transverse deficiency of the maxilla is associated with increased airway obstruction. if you look at this beautiful paper, which has been published very recently by Eric Teller, if you look at this graph on the right side, on the y-axis, you have the distance, that is intrapremolar distance and intermolar distance. And this is obstruction on dice. 0 is no obstruction. Look where the patients with no obstruction are. They have increased distance, whether it is premolar or molar. As you go down, this is 50% airway obstruction. This is 100% airway obstruction. Look at where the distance is. There is lots of correlation. Let it be in terms of a sleep study. Let there be correlation in terms of drug-induced sleep endoscopy. The evidence is very clearly out there that transverse deficiency of the maxilla is associated with increased disease burden. So what are all the treatment modalities that we have? Of course, I'm not talking about the MARPI. Of course, that's something that I think Nivi is an expert on. But I can talk to you all definitely about surgical expansions of the maxilla. And I know that we have a maxillofacial surgeon who is going to speak after me. But I will speak about it through the lens of an ENT surgeon. So as a treatment modality, we have three kind of treatment modalities that are available to treat transfer deficiency of the maxilla. They are the DOE, which is distraction osteogenesis maxillary expansion from which has got published in 2017. The EASE, which is also from the Stanford background by Professor Casey Lee, which got published in 2018. And the 2-pen, which is, as the name suggests, from University of Pennsylvania, from Raj Dedia and group, which is the latest to get published in 2021. They all are designed to accommodate your tongue, improve the transverse deficiency of the maxilla. So each one of these have come with their own advantages. So this is a short video that I would like to show as to how we sort of do this particular procedure. This is a patient who is a teenager for whom the maxilla is completely fused. Is the video running, Nivi?
Yes, yes.
Yes, Srinivas, it is.
Thank you. Thank you. This is something that we, with our orthodontists, our maxillofacial surgeons, and us, all three of us are in the OT. And when we do this particular procedure, just to show how it basically is. So we just, you can do this in two ways. You can actually give a crevicular incision and do it, or you can give an incision higher up. Us ENTs like to give incisions higher up, but our maxillofacial surgeon actually loves to give a crevicular incision because it's cosmetically sound. As you can see here, we are doing a Leafort 1. The difference when you do this with the Leafort 1 that is done for a patient with a double jaw surgery is that you are not doing a pterygo maxillary disjunction when you are doing expansions for as in the form of whether it is dome or sarme. But in EASE, which is Casey Lee's procedure, they actually do a pterygomandibular disjunction. That may be the difference in terms of what you are getting at the level of the posterior nasal spine. When I talk to you in the results, and when we talk about the results of all the three procedures, I will talk to you about that. So this is something that we are doing now. This is called endoscopic dome because we as, is the video running? Okay. Oh,
Video is not running right now. You're
okay.
back on your slide.
Yes, let me just, yeah, is it running now?
Yes, yeah.
So because of the expertise as we as ENT surgeons can sort of throw in, we have now completely shifted to doing these procedures endoscopically. So now you can see on the floor, you can see the floor of the nose. This is, we are cutting the septal attachment to the maxillary spine. And I'll sort of let it run a little bit. This we're cutting the septal attachment to the maxillary crest. This is the floor of the nose. So we, with the suction elevator, we are in the midline of the nose. We have, this is the floor of the nose. And as you know, in these patients with transverse maxillary deficiency, they obviously don't have too much in terms of floor of the nose. So now this is completely getting elevated. Now this is the vomer that's coming into view. And this is almost like a two-surgeon forehand technique, us and the maxillofacials together. So this is the vomer. And if there are any bleeders, you can actually cauterize it. So once you nicely elevate this entire thing on the floor, be careful not to sort of go all the way back into the nasopharynx. That is where, so now you can actually see the keel of the, the rostrum of the sphenoid slowly coming into view. This is the, you can actually see the dip going in. That's the posterior choana. So now we're using a Fisher burr to start the midline sort of a cut. You can also use beautiful piezo devices. But this is how, this is the spine, and we're going in. So by using it endoscopically, you are able to beautifully guide your burr all the way posteriorly, because your vision is much better because it is endoscopic. Now we go through all the way back. So this is, like I said, a two-surgeon forehand technique. So once we've done this, so you can actually make complete transection here. You can go all the way and all the way backward. So now from anterior to posterior. So now we're just trimming the little bit of the, so making the fissure there. And you can use a conical burr to sort of shape the anterior ANS, if we like. So now we're going all the way from ANS to PNS. So you can just trim it a little bit using a conical burr. The same principles we use in actually pituitary surgery is what we are using here now. It's two-surgeon forehand technique. So once that is done, you can actually, again, it's not about the tool. You can use a burr, you can use a piezo device, whatever it is. I feel the piezo takes a little longer time to cut, so we just use the device, especially when we are using it to do SARMAs. So this is the piriform aperture, as you can see. And now that is done. So you can see the entire thing completely split. And we can use the osteotome to give those final two cuts to start expanding. So that's how we do it completely endoscopically. So doing these few steps and widening the piriform aperture actually further increases the space available for the patient. And this is something that we are now collecting data. We use rhinomanometry to collect the data on patients. So this is the piriform aperture. And we drill the piriform aperture while we do the dome itself to increase the space available for the patient to breathe, which is proved not only subjectively through an instrument called the nose questionnaire, but also via rhinomanometry, wherein we can actually measure pre and post surgery how much the patient is really improving in terms of the amount of air that's going in. So this is what I would like to talk to you about. On this side, you can actually see the results of dome. On here, you can see the results of two-pen, and on the floor, you can see the results of endoscopic assisted skeletal expansion. This is by Stanley Liu, this is by Raj Dedia, and here by Casey Lee. Now, each one of them had their results very differently, but I would like to draw your attention to the nasal floor width, anterior, posterior. So if you look at all these, so nasal floor width, anterior, that is at the level of the anterior nasal spine, before, after, posterior nasal spine, before, after. Again, here, if you look at anterior nasal spine, posterior nasal spine, and if you look at here, the posterior nasal spine, anterior nasal spine, looks like if you compare all these reports, and to my eyes, and I'm sure all of you guys are looking at it, to my eyes, I think ease sort of gives in a little more edge over the earlier, the other two sort of results. And I would definitely take your Nivis and the maxillofacial surgeons' inputs as well. But to my eyes, it looked like the ease has an edge over the other two. Now, why is that so? So if you carefully sort of look at and read through the clinical technique, what ease does is that it actually does the pterygomaxillary disjunction. That, I think, increases the space at the level of the PNS. That is also called as the nasal floor width at the posterior. I think that sort of throws in a lot of space at the PNS area, because PNS expansion is very, very important. Why is PNS expansion so important? Because the entire muscles that are attached to the pharynx are coming from that area. They're all attached at that area. So expanding at the level of the PNS is very important. So when it comes to palatal procedures for us, what has significantly changed is the role of Bob, how Bob has sort of come into the picture and has completely changed the way we do surgery. Bobs have Bob sutures, which I'll describe to you. Let me just bring that. Bob sutures are sutures that have, and I'm sure some of you may be knowing this because these are like threads that you put in the face for lift. So this actually holds on to the muscle and locks itself and improves the muscle tone. So there are lots of techniques that are available. And this is one technique. For want of time, let me just quickly show how with minimal sort of a surgical intervention, you will be able to use a suture. Yeah, just putting that suture there and bringing the whole wall forward, the lateral wall forward. And the entire procedure just takes about 20 minutes. And you can see how the lateral wall has completely come forward and reduces the airway. This is another procedure, again using... So there's a lot of literature that basically is now published that shows that BARB is here to stay and is associated with pretty decent success rate of about 82%. What about tongue-based? I don't want to talk to you too much about tongue-based surgery, but the only thing that I need to for you all to understand is that tongue-based actually has to be phenotyped. All tongue-based procedures are not the same. The tongue base can be because either of macroglossia that is happening because of lymphoid tissue getting aggregated, or whether there may be just muscular tongue base, relative macroglossia, or the tongue is just falling into the upper airway because of a high arched palate or a poor muscle tone. If you give one kind of a treatment to all of these, calling them tongue-based collapses, we will obviously not get proper results. Hence, phenotyping your tongue base is very important when you give your treatment modality to your patients. So there is going to be a huge influx of pharmacotherapy that's coming into not very far from today. We are going to get medicines to use for right now. Atomoxetine and oxybutine are almost the drugs that are on the horizon to use to improve upper airway, and you can look at the amount of AHI reduction that these drugs are causing. So drugs are also going to come and change the way we manage obstructive sleep apnea. But again, the drugs have to be given to the patient whom you have understood the underlying mechanism. You can't keep giving. So these drugs will work for patients in whom muscle tone is the issue. If you give this to a patient who is having problems with sleep apnea because of carbon dioxide retention and hyperventilation, obviously you will fail. And hence, understanding the patients is very important. A small word about epiglottis collapse. Epiglottis comes in two forms, this kind and this kind. This is much more common. These are called primary epiglottic collapses, which happen independent of the tongue-based collapse. But please remember, if your patient is a mouth breather, just closing the mouth can sometimes treat the anterior collapse of the epiglottis. So again, seeing the patient's video while treating matters a lot. This is secondary collapse happening because of tongue base. There is complete collapse happening at the level of the tongue base because of. So this is not a primary epiglottic collapse. This is a secondary epiglottic collapse. So we need to understand that OSA is a complex condition with multiple comorbidities, personalization, and you cannot treat a patient in the form of this set of patients, I will give this kind of treatment. No, you cannot do that. And please don't look at obstructions. Look at relieving resistance. And please don't be a one-trick pony. That means don't be somebody who, just because you're a surgeon or just because you are somebody X, Y, or Z, because you have a hammer in the hand, don't be one of those Genghis Khans who will only deliver one kind of treatment because you are only looking at it through your narrow field of vision. So please don't be a one-trick pony that will offer a single modality of treatment for your patient. You should be more like Neo in Matrix. No matter how the patient presents to you, you should be able to stop all kinds of bullets that come in all your directions. Management of sleep apnea is a team effort. It is like an F1 sort of a pit stop, wherein you imagine this to be your patient. This is your dental colleague. This is your maxillofacial colleague. This is your ENT. This is your pulmonologist. This is your neurologist. This is your endocrinologist. So all of you together should be taking care of this patient. And success lies only in team effort. Thank you very much. And thank you for putting up with all my technical glitches.
Oh, not at all, Srinivas. Thank you. Excellent talk as usual. Very informative. Learned quite a bit about the ease technique. Even I wasn't very familiar with that.
That's
It's
Casey's.
exciting.
Yeah.
Exciting to see that. Yeah, yeah. Anybody has any questions can unmute yourself. Ritu, I think you had a question.
Yes, I have question with Srinivas sir.
Yes,
Sir,
Ritu.
DICE is not possible for every patient and it is not available in all these cities. I am from Indore
Okay.
and so I do not know who conduct DICE even in Indore. Matlab, I haven't heard anyone. So how can you differentiate when it comes to treatment modality? It always comes to my mind what should be best for the patient. Then ultimately I have to go with either mandibular appliance or either CPAP therapy. That
Correct.
is the only thing that comes to my mind. But when I heard you about DICE and the screening procedure and how you determine what is best for the patient, so is there any other clinical way you can determine this is best thing to go with?
So I think evaluation is the key, Ritu, and I completely understand that you cannot do DICE anywhere. But what you can definitely do is you can actually get what is called as a CineMR, which is available in most of the cities, and I'm sure Indore has it. CineMR is another modality which actually helps you to look at the soft tissue component and the skeletal component and the how the different structures are behaving in the upper airway. Once you do a CineMR, which is a dynamic assessment of the upper airway, you will get a fantastic understanding of how the airway is behaving during a patient's sleep. And please remember that this is in patient's natural sleep. So CineMR is a very good technique that you can use.
Thank you, sir.
So, Dr. Srinivas, on the same lines as DICE, when we make a referral to the ENT surgeons for evaluation, how critical or how important is the vote classification?
So that's a good question, Nivi. See, the thing is, DICE comes with its own baggage of problems, right? There is good and bad for everything. But as of right now, I think it is sort of getting a lot of accolades in terms of how it's able to describe the upper airway and how it is able to sort of and give the person understanding when you do treat different treatment modalities. For example, you can do an Eschmark maneuver and see how the airway is responding when you want to do a titration of your mandibular advancing device. Now, what is the most published or most evaluated classification? In Europe, they use what is called as the NOHL classification. Nose, oropharynx, hypopharynx, larynx, also called as NOHL classification. Now, the Americans say nose is a static obstruction. Why should you evaluate a static obstruction during sleep endoscopy? You don't need the nose.
Okay.
Whereas the Europeans say that nose is an integral part of the upper airway when you evaluate, and we all agree to that. That when you're evaluating, why don't you evaluate everything so that you have the contributions of the upper airway during sleep at that time? So when it comes to pediatric airway, because the adenoid sort of comes in, the supraglottic comes in, lingual tonsils come in. So in pediatric, again, there is a different kind of classification. But the simple answer to your question is, what is simple? In fact, oversimple, easy to sort of score, and has been thoroughly validated and has the maximum number of papers published based on vote.
Okay, makes sense. So if the dentist were to communicate with the ENT surgeon, what would they look for? What would they ask for?
And I would actually encourage the dentist to sort of come in and do the dice together with the ENTs, if time permits, of course.
Right.
But because see, we look at the elephant differently, you look at the elephant differently, but we are treating the elephant. So if you bring both the datas together, our understanding and your understanding, it brings, but if in
Dr. Srinivas, you are
muted.
muted.
Yes,
Yeah.
yes, yes.
Yeah.
Right.
Okay.
So what I'm saying is, if the if the dentist cannot come to the dice suite, at least the video should be discussed between the airway aligned dentist and the ENT to sort of discuss what are the different modalities that can be done. More often than not, just closing the mouth a lot of times just clears the tongue fall or clears epiglottic collapse. Small things like this helps and goes a long way in treating our patients. So it's all about communication, either to be there while the dice is being done or discussing the video together and talking to the patient.
Makes sense. Yeah.
Yeah, Dr. Srinivas, do you know anyone who's doing dice in Delhi?
Oh, lots.
Because I asked my ENT surgeon, if you are aware, Dr. Meena Agarwal is there in our hospital. And though she said ki here dice is not being done, but you can go for functional MRI, she suggested.
So that's the one that I talked to you about. But the problem is, I think I'm echoing. Yeah. So functional MRI is also very good. It's CMR, but we will not be able to look at how the mandibular advancement device is working in
Your
that
voice
particular
is
patient.
having lot of echo.
What, Ritu?
Lot of echo in your voice. So
Ritu,
I think you have on two devices in the
I
same room.
don't have two devices. Oh,
I
let
think
me
lot
just.
of people have unmuted to ask questions, so that's the reason.
No, you use two devices in one room.
No, it looks like everybody is echoing actually. Ritu, even you're echoing.
Right.
Okay, Srinivas, go ahead.
Are there some questions in the chat box?
Srinivas sir, good morning.
Good morning.
This is Yavar sir.
Yeah, Yavar.
Sir, I sometimes see children like maybe 12 years or 10 years with only mouth breathing and no snoring.
Right.
So how would you suggest to me to manage those patients? Should we refer them to a dental colleague for
Yes.
the mouth breathing?
Yes, 100%. Because
What? Yes, sir.
the reason is mouth breathing can result in a lot of problems. We know that just breathing through the mouth during the night increases the airway resistance by 2.5%, or to be very precise, 2.2. So what we are looking at when the child is mouth breathing, it's telling us that there is flow limitation. Because during sleep, nose is the preferred way to breathe. And we know kids are obligatory nasal breathers. So a dental evaluation for us ENTs is very important, so that they can look at how the dentition is and why the child may be having a particular problem. Because if we can catch it at this stage, because see, sleep apnea is a process. It just doesn't become snoring one fine day. It is gradually growing from occasional mouth breathing to persistent mouth breathing, from snoring to upper airway resistance syndrome to OSA. By the time the patient comes to us, we are already looking at stage 4 disease. The idea is about catching these kids earlier, the moment they show their manifestations. And our dental colleagues can actually help us a lot in this.
One more thing I need to ask is like the patients come for this analysis, na? Like they are having some dental issues or something, and we see that palate is collapsed, narrow arch is there. I send the patient to ENT evaluation for nasal patency so that I can correct mouth breathing by maxillary expansion and all that. But what happens is ki people are like, parents are like ki ENT is suggesting a surgery and our kid is so small, we won't go for the surgery, tell us some non-surgical method. But if the nasal patency is not there, what can we suggest?
That's very true, Dr.
So, and generally, like ENTs also, what I have seen is ki they don't recommend nasal surgeries until a certain age has come up. Till then, the mouth breathing is so predominant that all the dentition and the arch and everything has already collapsed.
Yes, true. I think it is important that the ENTs themselves know their subject. I don't have an answer for that. Maybe you should educate them more. I have learnt a lot from my dental colleagues.
How much so ever a dentist says, now go to a ENT and get your nasal patency corrected, the patient runs away. They are like, कि पता नहीं ENT वाला मना कर रहा है, why this doctor is after my life.
No, I think we have to talk to them, invest some time, give them brochures.
Dr. Nevi, can I intervene?
Yes, please go ahead.
Yeah. Just to add up to the question what Madam asked, there are two situations where it is echoing.
Yeah, Ram, for some reason, everybody is echoing actually.
I don't know, something to do with that. I need to go. Maybe it's me also.
No, I've taken back the host thing.
Host
So
thing,
I'm
right?
running it through here.
Others can mute probably. Okay,
Yeah.
now it's better. Yeah, you can think of two types of dental intervention, ma'am. One is a habit breaking appliance, which will try to stop the mouth breathing habit. Second is the myofunctional appliance, which will help to expand because it is a growing stage and the sutures have not yet fused together. The maxilla will beautifully expand at that stage. Even without a direct nasal surgical intervention, if you can start off with a conservative non-surgical myofunctional appliances, that will go a long way, giving confidence for the patient and the parents, and then probably at a later date an ENT intervention.
Yeah, actually what I am doing is I am doing palatal expansion so that the oral cavity is expanded, and I am doing myofunctional therapy. I am giving tongue exercises and everything. But the
Very good.
myofunctional exercises don't work if the nose is blocked. If the these trabeculae and everything is turbinate and everything is engrossed, the glands are inflamed and everything, then the whatever I do to correct the mouth breathing, it is not happening.
That's
But
exactly.
myofunctional appliances will help, definitely help.
So, Dr. Kumar,
It's only a combination.
Dr. Ram Kumar.
Yeah, please.
So again, it is exactly the same as if we have a hammer, we want to hit the nail. So the thing is, each patient comes with different kind. So every adenoid need not be removed. Every turbinate need not be shrunk. Right? So it depends on if there is an intrachoanal adenoid, grade 4 intrachoanal adenoid, where the adenoid is coming to the nasal cavity and it's clogging the airway. No matter what you do, that won't, no matter what you do, your device won't work. If you have a grade 2 adenoid, maybe an adenoid which is just threatening you to cause obstruction, in such cases it will. So it is always about each patient being discussed simultaneously between us and the dental to customize the treatment to that particular individual.
Yeah, that I
Yes,
do.
yes, I agree.
ENT. So she's very cooperative and she's very helpful also. She explains everything to the patient and she tells me that this surgery is required, but your patient is not agreeing.
That's a different battle.
Yeah.
Even pediatricians discourage any sort of surgical intervention until age 8 or 9 for the tonsils or adenoids. That's another issue.
Again, I think you will have to talk to your ENTs more because those are very old concepts.
Correct. So, Srinivas, one more comment about it is, I know not all ENTs are sleep aware or airway aware. And I think that may be the difference as to what the other doctors are commenting about. Is there a listing as to how we can get hold of your ISA doctors?
There is.
There may be a good way to connect our dentists
Correct.
and ISA doctors.
Correct. So there is a website, the ISA website,
Right.
and there are ISA members. So what I can do is I can actually add you or whoever wants to be added into that group,
Okay.
because there are now we have 600 members throughout the country.
Right. Okay.
So I think there will be one in every city, every town.
Correct. Yeah, my personal experience is when I met some of the ENTs at the Hyderabad meeting, it was amazing to see like-minded people. We were all thinking of the same thing. As
Right.
opposed to if I were to talk to the ENT down the road, the thought process are very different. So I think that's a good way to connect. And yeah, excellent presentation today, Doc.
Thank you. Thank you.
Very good presentation. Learned a lot. We hope to have you back in future also.
Would love to come back.
Thank you. Thank you so much. And our next talk, Srinivas, we have